that there are three major components of this injury and another possible fourth component. The three major components include the coronoid fracture, the radial head fracture, and the lateral collateral ligament injury from deep to superficial. These three are absolutely consistent with every terrible triad injury. The fourth component, which may or may not exist, is the medial collateral ligament injury, depending upon the force which causes the fracture. So these three components from the lateral side definitely need a repair. You may also need to do something on the medial side. Now, how do you decide which approach to take first and which approach will fix what kind of an injury? So as you know, the radial head and the lateral collateral ligament can only be approached from the lateral side. It is difficult to approach it, or rather impossible to approach it from the medial side. The medial collateral ligament will require a medial approach, but medial collateral ligament is not torn in every terrible triad injury. So the decision making becomes now a little simple. It is the coronoid which decides what approach you will take first. If it is a tip fracture of the coronoid or a type 1 or a small coronoid fracture, it is possible to fix this from the lateral approach only. But if it is a large fragment, an anteromedial facet, which again Ashish told you, which includes the sublime tubercle and insertion of the medial collateral ligament, then you need to add a medial approach to it, and that medial approach is taken first. So now your decision becomes a little easier. If it is a type 1 odiscal type where there is just a tip fracture, you can take a lateral approach. If it is a type 2 or a type 3, a larger chunk of the coronoid, you need a medial as well as a lateral approach. So lateral reconstruction, you go from deep to superficial. The coronoid fracture is fixed either by pull-through stitches or by a suture anchor or whatever method you choose to use it. The radial head is either fixed or it is replaced, and the lateral collateral ligament in an acute case is resutured to the center of the axis of rotation, or you may need to reconstruct it if it is a late presentation. On the lateral side, what we have been taught to access the radial head is the Cocker's approach. The Cocker's approach is between the anconeus and the extensor digitorum communis muscle. It's a little posterior, and through this incision you get excellent approach to the radial head as well as the lateral collateral ligament. But if you have to reconstruct the coronoid, the Cocker's approach becomes a little problematic because you have a large muscle anteriorly which you need to retract. So if you have a coronoid fracture, then you need to take an extensor digitorum communis split approach. This is what is shown as the E here. That is a little more anterior to the Cocker's approach, and from there you can access the coronoid, and then you can take a pull-through stitch or whatever else you want to do, and then fix it up. Radial head fixation through this approach is also not a problem. Medial approach you need to take, as I said, when you have a large medial fragment of the coronoid, and definitely you need to fix this. So this is your primary approach. You open it from the medial side, fix the coronoid, and then you go back on the lateral side and then do your lateral ligament reconstruction. So lateral side repair, the coronoid, radial head and the lateral collateral ligament. Then you do the medial side, you do the medial collateral ligament repair. And if all of this fails, or if your elbow is still unstable, then you are left in a salvage situation where you just have to put a hinged external fixator, allow the tissues to heal, and then cross your fingers and hope that the patient gets a good range of motion. So that is the algorithm. That is, as I have said, you can go through this. Exactly what I have said is just put in a tabulated form. One case I will discuss, a radial head fracture with a posterolateral dislocation. A coronoid tip is fractured. You can't see it because the elbow is not reduced over here. There's a small avulsion, and when I opened it, it was rather than the bony avulsion, it was a capsular avulsion. So I had to fix it with a pull-through stitch, and radial head was replaced because I couldn't reconstruct it. And this is a 2-month follow-up, and she's got a reasonable range. They always have some amount of flexion deformity because when you pull the capsule anteriorly, you sometimes over-tighten it, and that will create a loss of extension. But otherwise, if you reconstruct it well, they get a reasonable good range of motion, and definitely they are in the functional range. Thank you very much.